Hello everyone, thank you very much for the kind presentation. The purpose of my lecture today is to talk about Osteo-Core-Plasty technique for subchondral bone augmentation. I have nothing to disclose for this lecture. Nowadays, we know that the joint is an organ made by different types of cells and tissues, like articular cartilage with chondrocytes, ligaments with fibrocytes, synovium, very important, with synoviocytes, subchondral bone, and bone marrow cells. They are all different cells, but they work synergistically to facilitate the biology and the mechanics of the joint. Look at this beautiful picture from my friend Dr. Jorge Chala. The subchondral bone is now a key component in the homeostasis and load transfer of the cartilage. So now, cartilage and subchondral bone are considered an osteochondral unit rather than as two separate structures. These base cells comes from the subchondral bone and brings the nutrients like oxygen, glucose, and biochemical signals to stimulate the chondrocytes and MSCs of the calcified layer to maintain a healthy cartilage. This vascularization, as we can see in this image, one single artery nutritia in the medial femoral condyle. And in this very nicely done draw by Madri, where we can see how this vascular complex penetrates the calcified layer to stimulate the cells and chondrocytes to maintain the cartilage. But what are bone marrow lesions? They are MRI findings in fluid-sensitive T2 and STIR images, but this is a very general concept. And another question is why the term bone marrow edema is no longer used. It is because histologically edema is present, but also necrosis, hemorrhage, fibrosis, and cyst. They all look similar in the MRI, but they are different pathologies or different stages. So that's why it's very important to divide in two big groups, a group of traumatic bone marrow lesion and a group of atraumatic bone marrow lesion, where there are different stages, like the so-called concept SIFC, this is the spontaneous insufficient fracture, or SONC, spontaneous osteonecrosis, that could be the next step after SIFC. And of course, earlier stages of OA occurs with bone marrow lesions. In this study published this year in the GBGS from the United States, the group of Aaron Crick and Daniel Saris from the Mayo Clinic, they evaluate 223 patients with SIFC, and they found that 1/3 of those patients needed a total knee replacement at 3 years. That's why it's very important to address and treat these pathologies in the early stages to prevent the organ failure. In this very well done systematic review by the group of Elisabetta Combe, Maurelio Marcacci, and Bernardo Di Matteo, published this year in the ICRS journal, they found 12 studies using injections to treat these bone marrow lesions. Between them are the PRGF or PRP intraosseous introduced by the group of Miquel Sanchez, and they show promising short-term results. The other technique is to inject synthetic calcium phosphate. There are several studies, but with high rate of conversion, total knee replacement, 30%, with some complication like leakage of the interarticular components. The other technique is to inject BMAC, and Philippe Nigou, this is the most experienced doctor who published this year in the International Orthopedic, a big group of 140 knees treated with BMAC intraosseous, and they found that only 18% of those patients needed a total knee replacement at 10 years follow-up. So that's why Dr. Gobi and the team tried to develop a new technique called Osteo-Core-Plasty, a minimally invasive approach for subchondral bone marrow lesions of the knee. This will be published this year in the arthroscopy technique, and it consists of 3 parts. The first part is the bone marrow decompression to decrease intraosseous pressure and necrotic bone marrow resection. The second part is the administration of the BMAC to improve the healing potential of subchondral bone through the medicinal signaling cells and growth factors and BMPs from the bone marrow. And the last part, and most important, is the transplant of living viral intact bone core segments as bone autograft to stimulate and induce an osteoconductive, osteoinductive, and osteogenesis effects. These are the surgical instruments, the bone marrow aspiration instruments to maximize the cell yield with this marrow solution introductory needle, and the aspiration cannula using a closed end with size holes to not dilute the sample with peripheral blood, and taking 1 centimeter from each dip and niche. The percutaneous bone graft harvesting is made thanks to the 8-gauge Treffin needle and the bone extractor, taking this bone dowel that under microscopy examination, this cancellous bone dowel microvascular network can be seen. In this video, we start the procedure with a standard arthroscopy to address the associated pathology. The multi-level aspiration is performed with this special needle, rotating the needle 360 degrees, and then using the same hole and the same kit, the extraction of bone dowel is performed. This is a concept that provides both biologic and structural components for an optimized environment for regeneration. In this step, you have to be very careful not to break the bone in the iliac crest. As you can see, this is the bone dowel with cells and the vascular unit. Targeting the lesion using fluoroscopy is key for the success of the treatment. Then, loading the bone dowel into the extraction tool is performed, as you can see, and delivering the bone graft into the cyst or into the lesion targeted with fluoroscopy. Then this autograft is impacted and filled with bone marrow aspirate. The indication for this treatment is only for patients with CIF, SON, or early OA that not respond for conservative treatment for more than 3 months. Don't forget to treat the associated comorbidities for the success of the technique. There are some contraindications for this technique. For example, poor quality of subchondral bone, osteonecrosis with collapse, or severe osteoarthritis. The advantages: this is a minimally invasive technique, only 1 step with no bone marrow manipulation. It does not burn any bridge, only you can review the process, and early post-op mobilization. Of course, we have limitations, lack of long-term results, lack of robust knee OA, and this is more expensive than a decompression alone or PRP. This is one of our cases, a 70-year male with a history of chronic left knee pain with no prior trauma, with tender over the medial joint line, no malalignment, nor instability. As you can see in this image, an hyperintense signaling T2 in the medial femoral condyle in the coronal and sagittal view with no extrusion of the meniscus. This is the targeting the lesion under fluoroscopy, the pre-op MRI with an improvement in a 2-month MRI, and the resolution of the bone marrow lesion at 12 months. Clinically, the patient at 1 year is doing well with no pain, almost asymptomatic with good flexion and extension, and no pain with the impact. Finally, another case, a lady very active, 53 years old, with a history of chronic pain, no trauma, no overload, mild knee fusion tended over the lateral joint line with no malalignment and no instability. This is the pre-op MRI showing a subchondral cyst indicating an early OA. The subchondral bone treatment under fluoroscopy. This is the follow-up, the pre-op, and at 3 months with a good result in the MRI. Significant improvement at 1 year follow-up in VAS, Tegner, IKDC, and CUS pain. To finalize, cartilage and subchondral bone work synergistically with the rest of the interarticular structure, so we need to treat the joint as an organ. Although there are promising results reported in the literature, however, there is no clear consensus on the indications and standards in these new techniques. We need randomized controlled studies with long-term follow-up to create a solid foundation for the subchondral bone treatment. Thank you very much for your attention.